Hello class and welcome to week 7 of Kin 353. You're at the home stretch of this course and I appreciate your weekly efforts in completing all of the assignments. And of course this week your final critical assignment is due, and it's a culmination of all the CAP assignments. So although this project is worth a large percentage of your grade, the good thing is that you've been working towards this. Each one of the CAP assignments kind of builds on the previous one, and they all are part of this final critical assignment. So you've already done pretty much all of the work, and so there shouldn't be a lot of cramming needing to do for this final week, or I'm sorry, this 7th week. So let me briefly cover what's due this week. The thumb taping video and rehab exercise documents will be turned in this week. And I just wanted to clear up something about the critical assignment, because there is 2 locations where you will be turning this in. And what you'll have to turn in is a presentation, which is like a PowerPoint. I think most of you do PowerPoint, so go ahead and create a PowerPoint with all the required aspects of it, which is it's all explained in the learning activities link. Next, the video demonstration of preventative and rehab exercises will also be turned in, and those will be done as like one preventative exercise and one rehab exercise for each of the injuries that you've chosen. And the links for those videos, or if you want to put all the videos on one link, you will list that link in as part of your presentation. It has to be somewhere on there so that I can access it. And please remember to make your videos public in the settings, otherwise I can't view it and that will delay grading. And like I mentioned before, you'll have to submit your presentation to 2 different places. One of them says check critical assignment for originality here, so that will be under the learning activities for week 7. You'll have to submit the document there, and then you will also have to do it on the next link, which is for TaskStream. And for TaskStream, there's a few more steps that you have to complete, but all of that is discussed in the document attached in week 7 learning activities. That goes over each step, but if you're still having trouble with that, please let me know. I'll try to walk you through it. So today I'm going to present this journal article by Binkley and colleagues on scaphoid fractures. This article is sort of like a systematic review, but more like a best practices document. So it's meant to give you some tips and a general overview of what it's like to go through a full rehabilitation of someone that has just suffered a scaphoid fracture. So the scaphoid sits just distal to the radial bone, and the reason we're taking the time to discuss is because of the some of the risk involved with this bone. When it gets injured, even the bone bruise can be very critical, but when we're talking about fractures, we know that the scaphoid doesn't have a whole lot of vasculature, meaning it doesn't have a lot of blood supply, and that creates problems when it comes to healing. The typical mechanism of injury is falling on an outstretched arm or hand, and so technically this can happen to most athletes. Anytime they're falling and they try to catch themselves, all the force that gets transmitted through their hand can end up right on the wrist, right here on the scaphoid. And when you're palpating someone, you're looking for the anatomical snuff box. You may have heard this term in your textbook or from a clinician, but essentially is when you make the person abduct their thumb, it creates this little divot right here just above the wrist. When you palpate in there, you're palpating the scaphoid. An athlete that has just fallen on their hand or on the wrist is going to have trouble moving their wrist. They're going to have loss of strength. They're not going to be able to grip very well. And that's going to concern you as a clinician, and you want to send them for imaging. That's usually the first thing that you think about. And radiographs or x-rays are usually the first type of imaging that a physician will prescribe. And this can be difficult with this bone specifically because um, on the initial X-ray, it may come up negative, and it may take some time for the fracture to actually reveal itself. And in fact, as many as 25% of the initial X-rays may come up as a false negative, meaning that there is a fracture, but it won't show on the X-ray. And sometimes physicians will treat this as a clinical fracture, and they'll still cast the patient for about 2 weeks, and then try another X-ray after that time just to see if they can catch it on the second X-ray. Now, the gold standard would be an MRI, just because it's more detailed. It can it's three-dimensional, so it can go um, deeper into the bone as far as imaging goes. But the difference, though, is the cost. Obviously, an MRI is going to cost a lot more than an X-ray, and depending on insurances, that could be a problem. So most times, radiographs, X-rays will be done until they can actually see the fracture, and then depending on physician and medical insurance, an MRI can also be done, and that would be preferred. Once a fracture can be determined, casting will occur, and it will last from 8 to 12 weeks. And again, this is normal just because of the risk involved with this bone not healing correctly. Now, casting works about 90% of the time, meaning you'll have a full heal of the bone. But there are times when you have non-union fractures, and this can create, problems like we mentioned before. And when you have that, then you have to move on to surgery. So between 5 and 15% of fractures result in non-union. So when you have non-union, then surgery is required where you need pins and maybe wiring. And even after that, you're going to have to go back into a cast and get another X-ray, another MRI. And one of the things that this article didn't cover is that if it comes down, to the point where we're not seeing enough healing, that there's still gapping between the bones, a bone stimulator can also be an option. And that's, it was beyond the scope of this article, but just so you guys know, that's also an option. I've had athletes that use that, and so the few times that they did use it, we did have really good results where the follow-up X-rays did show good approximation. And just to kind of put a bow on this, the reason we take so much care in diagnosing this injury and making sure that we give the proper treatment is that without proper healing, you're going to have avascular necrosis. So basically death of the tissue of that bone. And that will create permanent damage, permanent disability, meaning the patient can't properly use their hand and wrist anymore. Limited range of motion and probably limited strength as well. So as rehabilitation begins, it's important to set goals with your patient. And in this case, we want to regain normal range of motion. We want to regain normal strength or baseline strength for our patients. And eventually you do want to get to the point where they can return to play and be able to do sport-specific activities. Picking a specific return date can be a big motivating factor for our patients. And again, you have to make sure you're clear with your patients that the goals are meant to motivate them. They're meant to set a date so that there's meaning to their rehabilitation sessions, but that date isn't set in stone. It may be delayed a little bit or it may come sooner, but it's good to always remind them that there is a goal and it may vary. So it just kind of depends on their tissue healing and how the rehab is going. The rehabilitation protocol set out here by Binkley and colleagues breaks up the program into 3 different phases: range of motion, strengthening exercises, and then more sport-specific exercises, which included plyometric types of exercises. Here is the overview of what this protocol will look like. Phase 1 is more of an endurance type of phase where we're just trying to increase range of motion, and this is going to take place during the phase where the patient is still experiencing some pain, probably some swelling, and we're just really trying to get their range of motion going. Phase 2, still increasing range of motion, but it's starting to include some strength endurance. Phase 2, or the late portion of phase 2, is more of a traditional type of hypertrophy type of protocol where we're actually adding weights and traditional exercise prescriptions. And phase 3 is more of strength and power, where we're pretty close to bringing the patient back to return to play. The next table here gives some specific examples of the type of exercises that the patient would be doing in each phase. So phase 1, weeks 1 to 3, would include active stretching, so flexion, extension, radial, and ulnar deviation, for example. And then as far as strengthening, it would involve more of isometric type of exercises, so like pushing against a wall with their hand, something where they're not really going through range of motion. Phase 2, weeks 4 to 8, still stretching, but now they can do some grip strengthening, finger strengthening, and then more wrist extension and flexion exercises as well. In phase 3, they continue to stretch, but now we're including some actual hand weights and also plyometrics, where we're actually doing some sport-specific type of exercises. An important point that the authors made in the article was that in each one of these phases, it's important to continually reevaluate the patient by testing, their strength, but also making sure that the exercises that they're doing in each phase is not causing extra pain, extra swelling, that we're not reaching too much. So, if we're working on isometric holds, that we don't immediately in the next session go to hand weight exercises. You want to slowly progress them from phase to phase, and there will be some overlap between these. That is not, uncommon. It's part of the way most rehabilitation programs are. There has to be a lot of overlap so that the athlete is not moved up in intensity too quickly. Okay, so let's say we go through this whole protocol with our patients, which will last about 3 months. Then how do we know that they're ready to go back to play? Well, like we stated earlier, one of our goals was full range of motion. And not just full range of motion, but also pain-free range of motion. And one way we can do this is compare the injured limb to the uninjured limb. That's typically the baseline that we try to use, because unless if you've measured all of your athletes' joint ranges of motion for every single joint before the season started, you probably don't have a baseline measurement of wrist extension, wrist flexion, ulnar deviation, radial deviation, things like that. And then of course you're also going to use the norms that you see in your textbook. But typically you want to compare bilaterally. Next, you want to see minimal muscular imbalance. So as far as strength goes, you probably would be manual muscle testing, wrist extension, flexion, and all the other ranges of motion. And you would also probably be taking a grip strength, and you want to do that bilaterally. So you want to test the uninjured side and compare it to the injured side. And before you allow your athletes back to their sport, a good rule of thumb is to make sure that they're somewhere between 90 and 100% of their uninjured side as far as strength goes. Next, as we noted, part of the phase 3 was to integrate sport-specific activities, and that's where we can start measuring functional ability. We can see how much of their sport they can actually do, and that will give us an idea of whether or not they're ready to return to play. And a couple points I want to make here. One is that the athlete should be progressed as they're returning to play, not just in the rehab exercises, but also within their sport. And what I mean by that is, let me give you wrestling, for example. Um, I rarely, I don't think I actually have ever returned an athlete from a severe injury where they were just in the clinic, for 3 months. And let's say today they finished their last rehab sessions and we're ready to return them play. Never have I uh, started them on a full practice the very next day. It's typically limited practices until they can do a full practice, and then they can do, an actual live event. And that's the way it should be for pretty much any other sport. You should be able to progress their practices. You start with limited practices, which are really good. But to do that, you have to know the sport pretty well. You have to be able to know how to break down the practices so that you can tell them, okay, today you're going to do 25% of what the rest of the team is doing, no contact, maybe only upper body or only lower body activities. And then each day, as you reevaluate them, you can add a little bit more. And the second thing is psychological competence, or just the aspects of the psychology of your athletes. It can't be ignored because it's such a huge part that goes into athletics that many people don't think about. And it plays a big role when it comes to recovering from injuries, specifically injuries like a scaphoid fracture, where your strength has been diminished, your range of motion has been diminished, and this is going to be the first time maybe that your athlete is going to actually test it out. Can they catch themselves? Can they put their full weight on the wrist? And maybe not just theirs, but someone else's if someone else falls on top of them. And it's important to assess your athlete psychologically. And I don't mean you have to be a psychologist or anything, but just knowing your athletes enough to recognize any hesitancy, or just being comfortable enough to ask them, like, hey, are you ready to go back to play? Do you feel like you're 100%? Do you feel like you can protect yourself if you need to? Um, those are the type of things that, as an athletic trainer, it's really important. Not just the objective measures that you see here, but also the psychological measures. And that's all I have for you today. I hope you guys took away some good points from this. If you have any questions on this or any of the assignments that are due this week, please reach out to me. Thank you and have a great week.